Good evening, everyone. Welcome to our Mental Health Conference 2020. We do apologize for the delay, but we are glad that you have stayed with us, and we are hoping that it will be a great opportunity for us to speak and for us to discuss about the investment opportunities for mental health. At this point in time, to open our evening's event, we're going to be asking Dr. Derek Harvey, the Senior Medical Officer of Cornwall Regional Hospital, to lead us in prayer.
Thank you, Dr. Crossman. Good evening, everybody. Let us pray. Father God, we'd like to thank you for the opportunity of life and the fact that during this time we are able to have a conference. Lord, we ask that your holy presence be in the conference to guide us in our deliberations and in our thoughts. As the theme says, Lord, you know the time for action is now. And you know that especially at this time of the pandemic, many persons are experiencing mental health problems. As we, the workers and the caregivers, consider the various aspects, we ask that you guide us in our deliberations. May the symposium be a successful one. May your holy presence be amongst us all as we deliberate these in Jesus' name. Amen.
Introducing myself, my name is Lisabeth Crossman. I'm the Regional Psychiatrist from the Western Regional Health Authority. It is so good to have you with us, and I'm so excited that you are a part of this group as we speak on the many aspects of investment in mental health. Given the crisis that we are all experiencing, the conference is very important and timely as we focus on the topic, investing in mental health. The time for action is now. It's never too late to do something. We welcome you wholeheartedly and hope as you journey with us each evening until Saturday evening, and then on Sunday when we close, that you will experience new things, that you want to be a part of this investment, and that as you go through the different speakers each evening, that you will all be able to be a part of the action, and that you will find something to do, even if it is investing in yourself and community. Welcome all, welcome as we share this evening, we welcome you. At this point in time, we have some special persons amongst us who will be bringing greetings. We want to welcome them at this time, and we want to say a special thank you to them as well, because if it were not for their organizations, we would not be able to host this conference. So we will have, bringing greetings for us, representatives from Pan American Health Organization, the Ministry of Health and Wellness, the Western Regional Health Authority, the National Council on Drug Abuse, and of course, the University of the West Indies Western Campus. So at this time, I present to you Mr. Errol Green, who is the Regional Director for the Western Regional Health Authority. Mr. Green.
Thank you very much, Dr. Crossman. Good evening, doctors, distinguished guests, ladies and gentlemen. It is a great pleasure to be here today to bring greetings at the beginning of this series of lectures and this conference to promote Mental Health Week 2020. This week of activities, I'm sure, will provide a valuable opportunity to highlight the positive steps that can be taken to promote mental health and well-being. The lectures and discussions will also again highlight the various barriers that can at times prevent Jamaicans from different backgrounds from seeking and accessing help with mental health issues. Discussions like these are important in building understanding of the fact that mental health issues affect people from all walks of life, men and women of all ethnicities, and from all socio-economic backgrounds. Promoting mental health and well-being requires an understanding of cultural diversity, including respect for differences and a willingness to learn and accept the different ways of viewing the world. The theme for this year's conference, Investing in Mental Health, the time for action is now. It's never too late to do something. The theme sets the tone for some very interesting presentations and discussions. As I mentioned, mental health issues are common and can affect any one of us. The reality is that especially as we go through the COVID-19 pandemic, a high number of Jamaicans will suffer from mild to moderate mental health problems at some stage during their life. And it is crucial that as a nation, we can provide the help that they deserve.
Since I works. But he should have called.
The figures may naturally be higher within our retired communities, where problems such as loneliness and isolation from friends and family can be particularly significant for older people, both in the community and in residential care. An important part of ensuring well-being is the assurance that all Jamaicans, regardless of their socio-economic and cultural background, are aware of and are able to access the help and services that they need. It is therefore crucial that we ensure that our primary mental health services have the tools and the resources they need to help and support the hundreds of Jamaicans who suffer from mental illness. It is also important that we encourage people with mental health issues to seek help, because through early detection, we can ensure that mental illness does not have to be a life sentence. Thanks to the work of our Minister of Health and our mental health professionals, over the past few years, attitudes in Jamaica have changed about the way we view mental illness. It is no longer seen as something that doesn't affect us, but rather as something that affects our friends, family, neighbors, and communities. This change has come about largely as the result of highly effective campaigns directed to educate Jamaicans on the seriousness and the sensitivity of managing mental health. These campaigns are set up to counter the stigma and discrimination that is often associated with mental illness, and has featured iconic Jamaicans, including our own Minister of Health and Wellness, Dr. the Honorable Christopher Tufton. These campaigns continue to improve the lives of thousands of Jamaicans, and it is important that we continue to build on these campaigns to ensure that those suffering from mental illness do not have to suffer alone. In bringing greetings at the opening of this week of activities, I laud the efforts of Dr. Crossman and the organizing team, because I believe that by building greater understanding across all cultures and communities, we can ensure that every Jamaican can discover that it is never too late to do something. I'm sure you will agree that Mental Health Awareness Week is vitally important in raising awareness of the continuing need to make mental health a priority for all Jamaicans. I thank you.
Thank you, Mr. Green, for those remarks and the greetings that you brought as well. Now, over the years, the Department of Psychology, Sociology, and Social Work of the University of the West Indies, Western Campus in Jamaica, has been very tremendous in the support that they have given to the Western Regional Mental Health Services, and especially at this time of our Mental Health Week. It is only fitting that they continue to partner with us, given the investments that they can make in making all mentally healthy. And at this time, we invite the director of the University of the West Indies Western Campus, Dr. Patrick Prendergast, to bring us greetings.
Thank you, Madam Chair. Honorable Minister, Dr. Christopher Tofton, distinguished panelists, distinguished ladies and gentlemen, all. You know, I'm always excited by the activities surrounding this week. It really underscores the strong partnership that we have developed with the Western Regional Health Authority, and many other health affiliates across the region. And so I want to take time out to express our gratitude to Miss Georgia Rose, who is the lead lecturer in the psychology unit here at the UWI Mona Western Jamaica campus, and her team, as well as, of course, our chair, Dr. Lisa Beth. I always say Lisa Beth, but Lisa Beth Crossman and her team. Thanks also to all the many sponsors of this symposium conference over the years. This year we are marking Mental Health Awareness Week, and this particular conference under the theme, Investing in Mental Health, the time for action is now. It's never too late to do something. These are indeed challenging times. Economically or financially, as some would say, physically, socially, and mentally or psychologically, as some would say. But whatever it is, we acknowledge that these are indeed difficult times. There is so much in terms of unbelievables happening around us as a consequence of the COVID-19 pandemic. People and institutions are pivoting, some pivoting from what to what, only God knows, but we know that we're in challenging times. Everybody is involved in a debate. Is it about the economy, or is it about public health? Or is it not just about whether these are two sides of the same coin? Are we not all in this collective trauma together? Do we not all have the same responsibility one to another to be safe, to be conscious, to do everything that we can to ensure that we all come through the storm together? I tell you what, emerging stronger together cannot just be about the collective learning new skills of coping, new norms for living, or for that matter, new normals of life. Even more critically, I think we need to come out of this with a deeper understanding and appreciation for the mental well-being of every individual in the collective. As we would say in the local spaces, when a man have him things together, it means him head spaces in the right position, no matter what the tribulations, no matter what the trials, no matter what the trauma. Calm, cool, and collected. Man have him things together. You know, in the early days of the pandemic, I made a point about the danger of infodemic, and I was accused of making up words. But my experience in behavior change communication and my insights about the uncontrollable ways in which information was being distributed across the multiple layers of available social media platforms had me really worried for the authorities in particular and the wider public in general. I knew that the open information flow and the in real-time communication meant that there would not only be a lot of misinformation, disinformation, mass information that for most times us end up confusing people more than anything else. And now what we see is that it's a challenge, therefore. The correct behavior would be totally vanished by the ongoing disputes between those who know, those who claim they know, and those who should know better. A lot of confusion. The solution to the disease becomes even more of a complication, and the management of behavior becomes a priority, which, by the way, would by now become even more difficult to manage because of the level of public trust necessary to navigate the waters safely would have been so eroded. But it is never too late to still do something. We at the UWI Mona WJC, as early as in April, included the issue of mental wellness in our first public forum on COVID-19, because we knew then, as we always knew, it is an often neglected matter. We at UWMONA WJC designed and executed not just a social media campaign for our students and staff around the importance of staying safe, but staying sane. And also the importance of embracing the value of showing compassion and care for each other. We also invested in psychosocial sessions for the entire WJC community. And when we say community here, we often boast that that goes way beyond our staff and our students. We at UWMONA WJC, as the records will show, and as our chairperson mentioned earlier, we are always seeking ways to support initiatives that strengthen the sustainability of institutional partnerships in mental health service. And so, as we speak about investing in mental health today, I want to use this opportunity to call on those who are able to, those whether they are in the Ministry of Health, wherever they are, to support our drive towards establishing a special and unique School of Human Services and Behavioral Sciences, which we believe would significantly help in advancing the agenda of applied research and practice in the area of mental health. There is some real meaningful work being done in the West. We know that. We can see it. But we also know that there is so much more to be done. So let us invest, not just in the human capital, let's also invest in the social and intellectual resources needed to bring about the healthy state of mind so we so desire as a society. These may be challenging times, but it's also a time of great opportunity to build a culture of care, to build a culture of stability, to build a culture of understanding and appreciating the need to invest in mental well-being. I wish you all a fulfilling and enlightening week. I wish you a productive and informative conference. And I say to you, stay safe and stay sane. Thank you.
Thank you very much, Dr. Prendergrass, and a lot of food for thought in how we move together in building a culture of care and stability to a better understanding of mental wellness, and how we can incorporate and invest in other resources apart from human, the social and other resources to bring about that change that is needed. Thank you very much, sir, for sharing those thoughts with us. We're going to move on to another very important part of our mental health investment bodies, and that's the National Council of Drug Abuse that has been working tirelessly in assisting persons who have become addicted to various substances and situations, and in helping them to maintain and to have a healthy lifestyle, as well as helping communities. We're going to ask at this time Mr. Michael Tucker, who is the Executive Director, to bring us greetings.
Evening, Dr. Crossman. Thank you so much. Good evening, everybody. Honorable Minister of Health, doctors, distinguished guests, ladies and gentlemen. Good evening, everyone. I greet you all well and trust you are navigating these challenging times as best as possible, both personally and professionally. On behalf of the National Council on Drug Abuse and our national stakeholders, would like to thank the Ministry of Health and Wellness's Mental Health and Substance Abuse Unit for organizing this conference. It comes at a time when investment in mental health and substance abuse is of critical importance, given that the COVID-19 pandemic has resulted in significant changes to life as we all know it. This current environment is at least the very best, at least a challenge for all of us, even for well-adjusted individuals considered to be physically, mentally, and emotionally well. National Council on Drug Abuse has seen significant increase in calls to our National Substance Abuse Helpline over the past 4 months, with over 200 calls between June to September compared to less than 50 during the same period last year. This may be an indication that problematic substance use may be on the rise. Jamaica is one of several Caribbean and Latin American countries currently participating in a hemispheric survey that seeks to determine the impact of COVID-19 pandemic on drug use. Surveys led by the Organization of American States and the Inter-American Drug Abuse Control Commission. A deeper understanding of the local context in relation to mental health and substance misuse is an urgent need. Beyond this is a need for exposure to regional and international best practice to guide practical evidence-based responses for general population and the most vulnerable among us. The relationship between mental health and substance abuse is well documented. International studies have shown that approximately 50% or more of the people suffering from severe mental illness also struggle with substance abuse. Locally, approximately 80% of the patients at Bellevue Hospital require specialized drug treatment in order to support their recovery from mental health disorders. While experts often debate over which comes first, mental illness or substance abuse, we know this is not a clear-cut answer, but there are clear connections. For instance, we know that people who suffer from mental health disorders often self-medicate with drugs and alcohol. More common mental illnesses that co-occur with substance abuse include depression, anxiety disorders, bipolar disorders, post-traumatic stress disorders, attention deficit disorders, and eating disorders. Ladies and gentlemen, recent local advances in this field of the treatment of co-occurring mental health and substance use disorders include capacity building among 140 mental health and addiction professionals in a range of modalities to address dually diagnosed patients such as cognitive behavior therapy, trauma-informed care, motivational interviewing, roles in multidisciplinary teams, and acceptance and commitment therapy. This was funded by the International Narcotics and Law Enforcement Unit of the US Embassy as part of a broader contribution to drug demand reduction in Jamaica. While this will go a long way in the improvement of care for persons who need it most, there's a need for more comprehensive national response that begins with policy to the formal adoption of a National Drug Control Master Plan, the incorporation of substance use in National Mental Health Plan, a range of other strategies that will be discussed in our contribution to the conference sessions. Again, I wish to congratulate and thank the organizers of this conference for attempting to expose us to a range of critical areas that have serious implications for development of a more robust national response to mental health and substance abuse. I hope that participants will benefit from meaningful engagement and that all will go as planned as we navigate this new virtual world together. Thank you very much.
Thank you very much, Mr. Tucker. And as always, we look forward to the participation in the rest of the conference as you highlight the needs in the substance use disorder area. At this time, we are going to invite Dr. Kevin Goldberg, who is Director of Mental Health and Substance Abuse in the Ministry of Health and Wellness, to bring us greetings. Dr. Goldberg, can you hear me? Dr. Goldberg, you have to unmute, please. Yes, sir.
Can you hear me now?
Yes, sir. Much better.
Sorry about that. So thanks, Madam Chairperson, Dr. Crossman, the Honorable Christopher Tofton, Minister of Health and Wellness, other special invited guests, ladies and gentlemen, boys and girls, good evening. It is indeed a pleasure to bring greetings on behalf of the Ministry of Health and Wellness at this first virtual mental health conference under the theme of Mental Health for All, Greater Investment, Greater Access, Everyone, Everywhere. The goal indicated in this theme has been the vision of our mental health services in Jamaica for decades. And when we thought we were getting closer to it, then came COVID-19 pandemic, a proverbial spoke in the wheel. However, COVID-19 has forced us to become more innovative and creative in continuing provision of mental health services, inclusive of public education. This very conference is an example in which a usually locally delivered public educational conference can have participants for the first time from over the length and breadth of Jamaica, from the Caribbean region, and indeed from all over the world. I'd like to pause here to commend the mental health teams across 4 health regions who have been working tirelessly to provide mental health service under these COVID-19 related constraints, not only to their regular patients, but to additional patients. These additional patients have a range of mental health issues which are directly and indirectly related to COVID-19 due to isolation, fear of being infected, loss of relatives and friends, compounded by loss of income or jobs. So the mental health teams, along with other healthcare workers, have been under tremendous strain. Hence, the ministry, in collaboration with its partners, have put in place supportive measures for healthcare workers, and will be seeking to augment the support as we enter community transmission phase of COVID-19. The Ministry of Health is aware that the general population are experiencing a lot of distress, and we're embarking on enhancing community psychosocial support, commencing with identifiable vulnerable communities and individuals, such as the elderly and children staying home to attend online classes. The minister will elaborate more in his speech. Additionally, for approximately 1 year, there's a Ministry of Health operated 24-hour mental health and suicide prevention helpline, where everyone, everywhere can access psychological counseling and referral and linkages to other psychosocial support. There has been a significant increase in calls to helpline in recent months. Number for this line is 888-639-5433 or 888-NEW-LIFE, NEWLIFE. The ministry is also acutely aware of the stigma attached to mental illness in all sectors of society, which include the health system, churches, workplace, education system, to name a few. Hence, there has been a ministry-led mass media mental health campaign for more than a year, which is encouraging well-thinking Jamaicans to provide safe spaces for persons to tell their mental health stories and for persons to listen and dare to care. So the campaign will be dubbed, Speak Up, Speak Now, and Listen Up, Listen Now, thus encouraging persons to cease from suffering in silence, but to access mental health care early. In conclusion, community transmission demands a community response. Now is the time for action, and each person within the sound of my voice has to do his or her part. Together, we can provide greater investment, greater access for everyone, everywhere to improve mental health care. And as always, let us remember that there is no good health without mental health. There is no good health without mental health. On behalf of the Ministry of Health and Wellness, I congratulate the organizers for staging this timely conference, and wish for you, the participants, a stimulating, thought-provoking, and productive engagement over the next few days. Thank you.
Thank you very much, Dr. Goldberg, for highlighting some of the investments that the Ministry of Health has made, especially at this crisis moment, and also for reminding us of the different ways in which we can access help whenever we need help through the helpline and suicide helpline. At this time, we need to recognize in our midst a member from our international organization, which has always sought to raise awareness to mental health issues, to decrease stigma and also discrimination. We invite Dr. Mitchell Heist, who is the advisor on non-communicable diseases and mental health from the Pan American Health Organization in Jamaica, to at this time bring us greetings. Dr. Heist.
Thank you very much, Dr. Elizabeth Crossman, Honorable Minister of Health, distinguished guests, everyone present. I bring you greetings on behalf of Dr. Bernadette Theodore Gandhi, the PAHO WHO representative in Jamaica, and Dr. Carissa Etienne, Director of the Pan American Health Organization, Regional Office of the World Health Organization, at the launch of this very important lecture series to commemorate World Mental Health Day 2020. It is indeed fitting that we meet at this juncture to commemorate World Mental Health Day under the theme, Investing in Health, the time for action is now. By mental health conditions, we refer to such conditions as depression and anxiety, neurological diseases such as dementia and epilepsy, and substance use disorders, like alcohol and other substances, the risk of suicide, and the associated psychosocial, cognitive, and intellectual disabilities. Most families have been impacted in one way or another by one or more of these conditions. We know that half of all mental health conditions start in individuals by the time they get to the age of 14 years. But most of these cases remain undetected and untreated. Emerging evidence has begun to show that there has been an immense influence of COVID-19 on youth mental health, including higher risks for developing mental health problems and mental disorders, such as anxiety, depression, post-traumatic stress disorder, and substance use. The Pan American Health Organization, in collaboration with the Ministry of Health, has begun to work to improve the mental health literacy of young persons in schools, the teachers and community members, so that those in need will seek care in a timely manner and get the assistance that they need. Mental health is more than the absence of mental disorders. Mental health is an integral part of health. Indeed, there is no health without mental health. Mental health is determined by a range of socioeconomic, biologic, and environmental factors. And what we do know is that there are cost-effective public health and intersectoral strategies and interventions that are able to promote, protect, and restore mental health. And it is important for us to be reminded of that. Jamaica is only one of few countries that has had the honor to complete both an investment case for non-communicable diseases and an investment case for mental health. The investment case for mental health has shown that by scaling up treatment for depression, anxiety, and psychosis, when one compares the costs and the benefits of scaling up such treatment, there will be a return on investment of $2.4 for every dollar spent after 5 years, and a return on investment of $4.2 on every dollar spent after 15 years of the investment. So in these times of the global pandemic, and when many are looking towards the end of the pandemic in order for us to build back stronger, it is very important that the need to invest in mental health is right there in the forefront of all decisions being made about the well-being of the population. I am therefore pleased to bring you greetings on the behalf of the Pan American Health Organization and to pledge our ongoing commitment to the Ministry of Health and Wellness and to our other partners in the efforts to improve the health and well-being of the Jamaican population. Thank you.
Thank you very much, Dr. Harris. And as always, we look forward to the partnerships in the investments, especially in mental health at this time. Ladies and gentlemen, all who are with us and have been journeying with us to this point, for those who have joined us, welcome. We are at the point where we are going to invite Mrs. Mullings Thompson, the Chief Executive Officer from Bellevue Hospital, to introduce our guest speaker. But before she does that, because after that you will be hearing from our guest speaker, Dr. the Honorable Christopher Tofton, our Minister of Health in the Ministry of Health and Wellness, I'm going to advise that for those of us who would want to have questions directed after the completion of the minister's discussion, that we write these questions in the chat, and these questions will be directed to our minister. So at this time, I'm going to invite Mrs. Mullings Thompson, our Chief Executive Officer at the Bellevue Hospital, to introduce our guest speaker. And after that, you will be hearing from the minister himself.
Good afternoon, everyone. Madam Chairperson, our specially invited guests, good evening. It gives me great pleasure to introduce our guest speaker for this afternoon, Dr. the Honorable Christopher Tofton, Member of Parliament for West Central St. Catherine since March 2016, is Jamaica's Minister of Health and Wellness. Prior to this, he worked as the Minister of Industry, Investment and Commerce, June 2011 to December 2011, and Minister of Agriculture and Fisheries, November 2008 to June 2011. Dedicated, passionate, and goal-driven, Dr. Tufton received numerous achievements during his tenure in public office. As Minister of Agriculture, he spearheaded the expansion of greenhouse farming technology and the creation of agro-processing facilities. Dr. Tofton redefined the sector's strategic importance to the Jamaican economy, repositioning agriculture as a business. This was achieved through modernization and restructuring of the ministry, expansion of extension services, revamping of agricultural research to be demand-driven, augmenting the marketing division, and creating the Agro Investment Corporation to mobilize investments in that sector. The same drive and passion was exuded when he headed the Industry, Investment and Commerce Ministry, where he focused was on investment facilitation, international market competitiveness, consumer protection, and the creation of a climate of confidence to attract investors. After leaving government in December 2011, Dr. Tofton served as the co-executive director of the Caribbean Policy Research Institute, a University of the West Indies think tank, while also serving as the opposition senator in 2012 to 2016. Dr. Tofton is a business strategist whose expertise includes international business and marketing strategy, specializing in foreign direct investment facilitation and the impact of public policy on industry. He has lectured and conducted business consultancy in Jamaica, the United Kingdom, and the United States of America in a number of areas, including international marketing, business strategy, and entrepreneurship. As the Minister of Health and Wellness, he has significantly led the move to improve the health services. Specifically for mental health, he has embraced the move towards more of a community approach in mental health. And during his tenure, he has commissioned the Mental Health and Homelessness Task Force that provided the roadmap to rebuild the community mental health services. He has pushed for training for more psychiatric nursing aides. He was instrumental in getting the mental health and suicide prevention helpline up and running. To note, it has been very useful during COVID-19 pandemic in reaching out to people and in quarantine and isolation that needed mental health support. And of course, he has helped in improving the community mental health outreach program by commissioning buses for each parish. And this was handed over in last year's Mental Health Week. In closing, a graduate of the University of the West Indies and Georgia State University, he received degrees in management studies and marketing, respectively. He completed his doctorate of business administration at the Manchester Business School, University of Manchester in the United Kingdom in 2002. Let us welcome our guest speaker for the evening, our Minister of Health and Wellness, the Honorable Christopher Tufton. Thank you.
Thank you very much, Mrs. Marcia Mullings. It is quite fitting that how you have described our minister, because he has really done a lot in the mental health field and in getting things organized in terms of investments and the many investments that he has made. I must apologize because he is a bit delayed. And I do apologize for that. But let me in the interim advise you as to the evening sessions for the rest of the week. On Wednesday, that's tomorrow, we will have two presenters looking at different aspects of investment in mental health. We have Dr. Earl Wright, who is a consultant psychiatrist and president of Jamaica Psychiatric Association, looking at public health and economic burden of mental illnesses. And following his presentation, we have strategies for addressing challenges of integrating mental health and primary care being done by Dr. Diane Campbell-Stenneth, who is the Regional Technical Director of the Western Regional Health Authority. On Thursday, we have Dr. Peter Gay Reynolds, consultant psychiatrist from Northeast Regional Health Authority, who will be looking at strategies for addressing challenges of managing patients on an open medical ward. And she'll be followed by Dr. Kevin Goldberg, who will be looking at reducing stigma associated with a career choice of mental health. On Friday, which is October 9th, we have Dr. Ganesh Shetty, a consultant psychiatrist who really focuses on children and adolescents, looking at reducing adverse outcomes in adulthood, taking care of our children. And this will be followed by a very exciting panel discussion looking at charting the pathway to improve the child mental health, having representatives from the National Council, the Ministry of Education, the NGOs. On Saturday is World Mental Health Day, and this is celebrated each year, October 10th. And this World Mental Health Day will feature one of our international partners in the person of Dr. Claudina Cayetano, who is actually the Mental Health Regional Advisor in the Non-Communicable Disease and Mental Health Department of PAHO. And she will be looking at overcoming barriers to equitable care. Is that possible? And following that presentation, we have a panel discussion, and that panel discussion will feature our professors from the university, Professor Wendell Abel, Professor Roger Gibson, members from the Ministry of Health, Dr. Judith Leiber, and of course, Mr. Michael Tucker from the NCDA. And that discussion will look at the blueprint for building the mentally healthy community. On Sunday week, which will be our closing session, we start at 11 o'clock, and we'll be looking at investing in mental health. The time for action is now. And Professor Benedito Saraceno, a past director of mental health and substance abuse in the World Health Organization, will be our featured speaker at that time. And we close on a Sunday. So for all evenings from Wednesday on to Saturday, we start at 5 o'clock, and Sunday for our closing, we start at 11 a.m. We look forward to your presentation because we are excited about this topic, investing in mental health. The time for action is now, and it's never too late to do something. It is always very encouraging during Mental Health Week because we actually focus on this day, which was designed by the World Federation of Mental Health many years ago, October 10th, to be World Mental Health Day. And what we try to do is to look at the mental health challenges that so often plague our society. We look at the health promotional activities that we can engage in to reduce stigma and discrimination, and also to empower individuals to make their lives better, even though they may be living with a mental illness because of what surrounds them. We also seek to prevent mental illnesses and find ways in which we can challenge individuals to reduce the risk of having a mental illness, looking at the various ways and the various components that can impact on their lives and therefore can result in their development of mental conditions or mental illnesses. So it is a day for us that we really look forward, amongst other days that we do it every day, but we specifically target various groups, various individuals to spread the message and to help us to spread the message, to recognize that, listen, there are persons who are living with mental illnesses, there are our brothers and sisters, and so we need to be able to work with them. We need to be able to find ways and means not to let them feel left out, not to stigmatize, not to discriminate against them, because as I always said, there but for the grace of God go I. So we want to use this medium to highlight some of the challenges that we may have, and also use the medium to exercise even greater care in taking care of our brothers and sisters, and also investing in our own mental health. Because if we don't invest in our own mental health, we will not be able to help others as we should. So ladies and gentlemen, I thank you for listening so far. I see we have the Honorable Minister who is with us, and I won't take any more of his time. I know that he has had a breather, he has cooled down a little, and he is raring to go. I can see the expression on his face. So I look forward to hearing from you, Mr. Minister, as we all do, and we look forward for the questions and the discussions after you are finished. I thank you, sir, for taking the time to be with us, and know that you have invested a lot in mental health, and I do look forward to what you have to share with us at this time. Thank you, sir, and the floor is yours now.
Thank you very much. Good evening, everyone. I apologize for the late start. Got caught up in Parliament where I had to give a statement actually involving COVID and mental health, so quite relevant to what we're discussing here. First of all, let me commend the organizers of this event. I think it is a real opportunity for us to ventilate at a very appropriate time issues around mental health, and hopefully coming out of these discussions, we would have advanced the narrative, the discussion, the understanding, and certainly the response to challenges around mental health. So, fear, anxiety, and stress have become a constant companion for many of us in the race to save lives while preserving livelihoods and seeing to the education of our children amidst the global COVID-19 pandemic. It is perhaps no more important than ever to pull out all the stops to preserve our mental health while responding to the psychosocial needs of others among us, and in particular, our seniors, our children, and our youth. At the same time, our current reality gives relevance and lends urgency to the theme for this year's World Mental Health Day, mental health for all, greater investment, greater access. Before I get into Jamaica's own efforts, however, and through the lens of that theme, I want to paint a more precise picture of what it is that we're responding to, certainly given our current COVID-19 realities and context. Up to October 4th, and I'm speaking now about our seniors, 514 of our COVID-19 cases were persons between 60 and 69 years old, 18 of whom have died. 449 were persons 70 years and older, 66 of whom have died. This is compared to 2,029 positive cases among persons 10 to 30 years old, only 4 of whom have died. The conclusion here could be many, but I think generally speaking, it is accurate to say that the recovery rate for COVID-19 decreases with increasing age, while death rates increase with increasing age. The number tells the story of the need and value of the interventions we have made to date, including requiring some of our older persons to stay home except to go out for items, including medication and food supplies. However, what we have to accept and have to deal with, and that's what I spoke to in Parliament earlier this evening, are the mental health consequences of these restrictions. Preliminarily, findings from a recent study by Professor Denise Lemaire, an expert on public health and aging, provides for us insights into what our older persons are facing. That survey was done 228 persons 65 years and older, with the majority of them, 74%, that is, are female. Some of the preliminary findings were as follows. 71% were very concerned, 26% somewhat concerned, and only 3% not concerned. At the same time, there was a large degree of compliance to basic COVID-19 protocols and restrictions. In other words, they stayed home, having been told to stay home. 89% reported leaving home less than before the first stay-at-home order in March. 98% reported wearing masks. sanitizing and washing hands to protect themselves, and 22% reported canceling a doctor's visit or other healthcare appointment. Very important to demonstrate the context or the impact. As a result, only 20% reported in-person visits with relatives, and 98% said they stayed in touch via phone. Again, very important. Speaks to loneliness and the consequences of that. Most appear to have been cut off, at least physically, from their usual source of social support. Approximately 50% reported church as their source of social support, while some 30% pointed to community groups and neighbors. And of course, we all know that restrictions on churches and other public gatherings have been a feature of the COVID response. About 75% said family and friends who they stayed in contact with by phone. On social distancing guidelines, most older persons reportedly believe they are necessary. Still, approximately 1/5 think the guidelines are difficult to do and impossible to continue for a prolonged period of time, while a third reported a lack of companionship, feeling left out and feeling isolated. As for children and youth, I'm sure many of us have heard the reports of young children insisting to parents that they hate home schooling while asking about their friends and the lack of interaction with their friends. All of this is bearing in mind what we understand of our young people and mental health from existing global data, which tells us that 1 in 5 of the world's children and adolescents have a mental health disorder. Suicide is the second leading cause of death among 15 to 29 years old, according to the World Mental Health Report 2018. And in Jamaica, persons aged 15 to 24 years and 25 to 34 years are among those with the highest overall prevalence of depression, in addition to those over 75 years. At the same time, 1 in 4 persons worldwide will be affected by a mental health or neurological disorder at some point in their lives. Add a public health crisis, the scale of COVID-19 to the mix, and we can see immediately the urgent need for action. Already, our mental health team is reporting, and anecdotally, and we're gathering more information to be more scientific in our conclusion, but anecdotally, an uptick in cases of acute psychosis, adjustment disorders, anxiety attacks, post-traumatic stress disorder, and protracted grief reactions. The World Health Organization has cautioned that while the main mental health impacts up to now relate largely to elevated levels of stress and or anxiety, levels of loneliness, depression, harmful alcohol and drug use, and self-harm or suicidal behavior are also expected to rise. This is according to the World Health Organization. It means, ladies and gentlemen, that there exists an urgent need for action to realize mental health for all, giving attention to scaling up investment and securing greater access to services. I want to pause here to make clear that when I speak of investment, I am speaking not only of financial resources, but also of an investment of time and attention to the emerging issues. The Ministry of Health and Wellness here in Jamaica has thought this process through, and we're not claiming to have all the answers, but we certainly have charted a particular course in dealing with this issue, some of which I spoke to in the Parliament today. That is, we have for too long, we think, been inconsistent in providing our people with a safe space to talk about mental illness and to share their experiences with mental illness, which are likely to become more challenging because of COVID-19. In so doing, we have created an environment where stigma thrives, even as we grapple with addressing the institutionalization, the multiple position facing the world's population, including not only pandemics, but also environmental threats and the mobilization of financial flows for mental health. The financial implications of the failure to constructively and consistently engage on mental health is staggering. The Lancet Commission on Global Mental Health notes an estimated loss of some $16 trillion to the global economy due to mental health disorders in the period 2020 to 2030, driven in part by the early age of onset and loss of productivity across the life course. The situation is such that of necessity, we must re-examine the quality gaps concerning in and outpatient care, as well as the prevention gap. Last year, I visited an NGO that caters to persons with mental illness in Montego Bay. And what emerged were a number of seeming quality gaps. They include the need to increase the manpower to serve the more than 6,000 patients with a mental illness on the register in the Western Health region, and the need to foster greater collaboration across sectors, not only to respond to the growing demand for mental health services, but also, where possible, to prevent mental illness and associated loss of productivity. It is against this backdrop that I earlier today announced, it is against this backdrop that I earlier today announced the rollout of the COVID-19 mental health response program in the Parliament, which is aimed at mitigating the progression of mental health issues associated with the COVID-19 pandemic. To bring about this outcome, we are adopting community-based support, creating ease of access to mental health services through community engagement and intervention, together with the mass media education to promote mental health and prevent mental illness. The program's components include increasing the skill sets of healthcare workers and community volunteers with the provisions of training in psychological first aid, targeted community interventions, such as volunteer service that provides our vulnerable persons with assistance in the execution of day-to-day tasks, such as filling prescriptions and purchasing groceries for those who are restricted, neighborhoodly check-ins with vulnerable community members, and the offer of special transport services for the elderly to get the essentials of life. Those are some of the interventions. We have also entered the second phase of the Speak Up, Speak Now campaign with our observation of World Suicide Prevention Day last month. That campaign aims to increase access to information about mental illness and the ways in which people are affected, bring visibility to available resources for persons living with or otherwise impacted by mental illness, and promote behavioral change to end stigma and discrimination against persons living with mental illness. It will also support the work of the new mental health response program. There's also the ongoing operation of the 888 New Life or 888-639-5433 helpline, together with the mental health webpage, www.moh.gov.jm/mental-health. Both of these offerings, ladies and gentlemen, have been to the credit of the Ministry's mental health support system. One of the 5 counselors for the helpline, for example, had up to 32 calls in April, compared to only 10 a month earlier. This, to my mind, is indicative of the growing need for mental health services. Since June, we have had more than 93 engagements on our message board, which is accessed through the mental health page, as Jamaicans share their feelings and thoughts regarding their mental health, while others provide a listening ear and feedback. We need to do more of this, particularly in the period of COVID. We have boosted community mental health service response with 14 new buses added last year to serve our 4 health regions, and increased the cadre of psychiatric nursing aides, some 35 of whom began work earlier this year. None of these measures have come without investment. Last financial year, for example, the government spent just over $3 billion on mental health. And there's a breakdown here, which I won't go through, but a number of things from compensating employees to supplies to supporting the infrastructure to pharmaceuticals. But the fact is, we're committed, and that commitment continues, even though with an increased demand based on the COVID challenge that we're facing. I spoke earlier about the quality gap. A necessary ingredient for ensuring better health outcomes for our people with mental illness is access, an important indicator for which is financial affordability. Currently, the National Health Fund provides a level of coverage for mental illness. For example, there are individual benefits for prescription drugs for persons with psychosis and depression. Some benefits also feature in the National Health Insurance Plan, the Green Paper for which was tabled in Parliament last year, and on which national consultations are to take place. I am aware that at least one insurer offers some benefits as part of their group health insurance. I am further informed that persons with a mental illness can access life insurance of up to $15 million, depending on the severity of the illness and subject to testing. I would certainly want to use this opportunity to urge all private insurers to take stock of their offerings in the effort to address existing treatment gaps. The fact is that mental health care can be costly, but the absence of the necessary enabling environment for the provision of that care is even more so. Frankly speaking, given what the data is telling us, consideration must be given to the prioritized inclusion of mental health within reimbursement and insurance schemes, and not as an option, but as a standard. In 2015, we had close to 108,000 visits to public mental health clinics for schizophrenia, psychosis, mood disorder, substance misuse, children, adolescent disorders, post-traumatic stress disorder, and organic mental disorders, among others. Some 83,438 of those were due to psychotic conditions. Counseling, psychotherapy talk, therapy is a vital ingredient for the recovery of patients with substance abuse or emotional problems. In mild cases, that counseling may be all that they need to recover. Medication, ladies and gentlemen, is only a part of the treatment that addresses chemical imbalance in the brain that causes signs and symptoms of mental illness. If the psychological component, which is addressed in talk therapy, is not afforded by health insurance coverage, then it becomes trust that you are also engaging in your own interventions in the home, at school, virtual or face-to-face, and in the workplace. This is an important issue that must be tackled, and I think it is only relevant that today we're engaging in this conversation. I urge all of us to not just allow the conversation to continue, but let us ensure that we back the conversation with tangible actions that can make a difference. Thank you very much.
Thank you very much, Mr. Minister. We do appreciate your coming and sharing with us. A lot of food for thought, and we have the questions coming in. The first question that I'm going to pose to you, sir. What commitments are in place for our children with special needs and mental health issues, those at risk for mental illnesses and those living with mental illnesses?
Okay, thank you very much. Repeat the question. I was talking to Dr. Goldberg.
What commitments are in place for children with special needs and mental health issues, those at risk for mental illnesses, and those living with a mental illness or mental disorder?
So I have my mental health expert in Dr. Goldberg here beside me, and he will go into some of the specifics. But what I will say is that we, over the last few years as Minister of Health, we have been working closely together in the first instance with our schools, the education system, where we have been training our guidance counselors and form teachers to pick up signs of mental challenges, mental illness challenges, and to provide minimal support, and then to create the links between the public health system and those young people within the formal education system. A lot has been done in that regard, I know, and it's continued. We continue to do so. Once those persons require the public health response, then there's a mechanism so to do to give the level of care that is required. It's that we have to expand, because oftentimes we misdiagnose a mental health challenge and we classify persons who may be deviant in their behavior as being a deviant, but not necessarily having a condition that requires attention. And I think it's something that we have placed a lot of emphasis on. But I'm going to ask Dr. Goldberg to chime in here if he wants to add any additional information around that.
Yes, thank you for that question. I just want to add that we realize we have a inadequate amount of child and adolescent mental health services and persons who are specialized in that area of psychiatry. So we are actually expanding our child and adolescent mental health services by increasing the persons who are trained in that area. So we're actually rolling out that child psychiatry fellowship. We should be starting on training more persons, nurses, and other persons in this area, so we can really detect persons who have these conditions early and put in place steps to make sure they have optimal outcome. We're also trying to work on also improving the rehabilitative skill capacity of our workers, because a lot of times people have disabilities, you know, again, to reach your optimal level of function with occupational therapists and other rehabilitation therapists to provide that kind of extra care for these persons so they can at least optimize their level of functioning.
Are you saying, Dr. Goldberg, just to sort of straighten out some things, are you saying that you have an operational child and adolescent fellowship and you are in the process of arranging training for occupational therapy?
Yes, we
for
have
the occupational therapist.
Next year, we should have the rollout of the child psychiatric fellowship, and we're working on having locally trained rehabilitation occupational therapists.
Okay. All right, great. Good to know. Okay, another question here. What are the plans for the psychiatric nursing aides in doing further training and dealing with the psychiatric patients in this new era?
Yeah, actually, the minister alluded to them because they need to also be trained in psychological first aid so they can offer the proper support when they go in the communities and visit patients to ensure the families are managing quite well and coping quite well. We also want to be involved in some rehabilitative care because a lot of times persons, as mentioned before in the minister's speech, is that person may be controlled with medication, so they have a clinical recovery, but they need to go on to functional recovery, and that's where they can assist this person to reach the optimal function where they can actually participate in the mainstream society.
let me add to that. So as it relates to COVID, what we have done is we've gotten permission and started to hire community health aides. We're about 800 now. We're going about 1,400 between now and the end of the year. They are trained in a range of things, but included in that, through the support of our mental health nurses, mental health aides to a lesser extent, they are going to complement and create an army of response at the community level. And they are going to be charged with doing some of the very basic things. They will learn enough to know to administer basic therapy. I mean, listening is an important part of mental health. To an old person who is at home alone and lonely, arranging for medication to be delivered. Those are important elements of the response. Now, if someone is more advanced in the challenges that they face, then a referral process would be triggered so that a more advanced mind could approach and deal with that particular problem. The other component of our mental health response to COVID is to engage civil society. And I will use the opportunity here to throw that out because that's important. There are a number of persons and institutions at the community level who already play an important role in giving psychosocial support or other types of support to those who may have challenges. The church, for example, church tends to be a very big player at the community level through whether it's the pastor or outreach programs that they have. Jamaica Justices of the Peace, the service clubs. And the one element of the program we are rolling out is to engage civil society, provide them with a sort of manual of some kind, a guide, to provide the very basic, the most basic being to identify those who are so affected, to provide basic support, but then more importantly, to refer so that we in public health can do some follow-up. And I think it's absolutely critical for the public health COVID response because the system alone with the officialdom in the system will not be able to deal with the problems alone. It has to be an all of society approach, and that's what we're trying to promote.
On with regards to how would the community and health practitioners be trained, Dr. Goldberg, to looking at the psychosocial first aid and other means of training. But the person went on to ask, from what source will the training material be derived?
Actually, the training material will be derived by two sources. The Jamaica Red Cross are partnering with us to provide us with a 4-hour training material that they can provide for persons who are so just volunteering for this process. And also, PAHO has a 12-hour online course which persons can do like self-learning at their own pace and complete that online training. And there are also one part with us where after that training, because we have webinars which will concretize what they have learned during the training. So we actually have training material that is readily available with roll out in a virtual way.
One question, there seems to be limited investment in education of mental health professionals. Are there any plans for scholarships or grants catered to students interested in psychology or at the graduate level?
Well, not that I know of. The truth is that we encourage advanced education in a range of clinical sciences, public health sciences. There are institutions that have been provisioned to provide support, the Student Loan Bureau, for example. But I don't know of any specific scholarship that the government now offers for whether mental health or otherwise. Maybe something to think about. But as of now, I don't know of any.
Okay. All right. Moving on to another question earlier. Are there any plans to make a unit for psychiatric patients at St. Anne's Bay Hospital, seeing it's a regional hospital for Northeast Regional Health Authority?
So St. Anne's Bay Hospital is one of 3 hospitals that are slated for major upgrade under an IDD improving healthcare program. And that hospital will benefit from a fair bit of expansion. It already has a mental health section that will further be enhanced and benefit from that expansion, which we're now in the design phase. So I anticipate a more improved and expanded mental health service in St. Anne's.
Okay, great. I'm just going to do 2 more because the time is going very fast. Is there any definite plan to move away from hospital-based care for psychiatric patients to community-based care?
Okay, so the mental health and homelessness task force report, which I had commissioned, chaired by Dr. Earl Wright, which was published, I think, in 2017. 2017, I think, has a significant bit of information around the future dispensation for mental health treatment. And a big part of that is deinstitutionalizing and enhancing community-based care. And we have started the process of preparing for that, because in deinstitutionalizing, means you need more outreach. So the hiring of additional mental health aides, the buses, the things that I spoke to in the presentation, and that is continuing, are all geared, including the public campaign to get the country to overcome stigma, which is a very big obstacle to community-based treatment. People treat the mentally challenged or the ones that have obvious signs or displays mental health issues as outcast. And that has to be overcome by getting the mindset change and the behavioral change. So it is a big task, but it is our policy now, and we're committed to working with it over time to get it regularized.
Okay, and the last question, Mr. Minister, given our time, is the government thinking of conducting a national psychosocial or psychophysical survey to possibly determine the state of the nation in general?
Well, the Earl Wright report did give some indication of where we are as it relates to mental health, and he drew on a range of other studies and experts and so on. It has been for me the guide that has influenced some of the decisions and the policies that we are pursuing. And that report was deliberately requested by me to provide some guidance. Whether we build out or do additional studies, I mean, from time to time we do things and we have partners that do studies. But as of now, I don't know that we are planning any major study beyond what is here. I do have an interest, I must say, however, to see the extent of COVID and the impact of our mental state as a country. And that's something that I would like us to look at, because living with COVID and post-COVID in 2-3 years, I think is going to shift the state of mind of a population and the world, for that matter. And I think it's very important for us to understand it as we seek to chart a way to create new services that are on offer to deal with mental health and coping mechanisms. So if you ask me if there's a need now, I would say now is a good time because of what is happening with COVID. And it's for us now to take that on and to advance that process.
Okay, Mr. Minister, I really thank you. And just a point of information, somebody shared that the mental health hotline is often unresponsive. So maybe as you leave from that space, you can discuss it later with the other partners so that we can make it more responsive. But thank you very much for sharing with us. We really appreciate your time. We know that you're very busy, but we know that you're very into investment in mental health. And we really want to thank you for that positive energy that you have put out in mental health. And we really feel it. And we know that we are going to be working together towards the investment in mental health. Good investment, greater access, mental health for all, everyone, everywhere. Thank you very much, sir, for your participation. And thank you, Dr. Goldberg.
You're welcome.
Thank you. Thank you very much. All the best.
Ladies and gentlemen, we have come to the point where we are going to be continuing in regards to our panel discussion, and we are going to be asking Dr. Goldberg to moderate that panel discussion. He will introduce the panelists, the panel discussion, and conduct the rest of the evening. I thank you for your attention and for allowing me to moderate. I thank for all of you who have stayed on with us. I thank you very much as we continue the journey. We will see you again tomorrow after Dr. Goldberg has ended. So just stay on for the panel discussion, and we will see you later. Thank you very much.
All right. Thank you very much, Dr. Crossman, for ably leading the first part of our evening proceedings. And we now will go into the panel discussion. And we have a lineup of panelists here that will help us to start a discussion about investing in mental health. What really are the returns? What are the returns? Are there returns in investing in mental health, or is it money not well spent? So to discuss that, we have four panelists: Dr. Mitchell Harris, Mrs. Yvonne Grant, Mrs. Moses Thompson, and Ms. Colette Curry. So what we're going to do, we have each of the panelists to give their opening remarks. And while they give opening remarks, you can post your questions. So at the end of the final panelist presentation, then we can ask them to respond to your questions and your comments and your feedback. So our first panelist is Dr. Mitchell Heist. And you heard before that she is a non-communicable disease and mental health advisor in the PAHO office in Kingston. And she will present her opening remarks now. So Dr. Harris, can you proceed, please?
Thank you very much, Dr. Goldberg. Can you confirm that you're hearing me loud and clear?
Yes, we are hearing you.
Okay, and I'll remain without the video for the time being. I'll keep with the 4-minute presentation time that we have been given. Investing in mental health. The presence of mental health conditions contributes to poor health outcomes, premature death, human rights violations, and global and national economic loss. Communities and individuals must be empowered to attain the highest standard of health, which can only be achieved when their mental health and well-being are also ensured. More than 80% of people experiencing mental health conditions, including those experiencing neurological and substance use disorders, are without any form of quality, affordable mental health care. It is also well known that people living with mental health conditions are more likely to face other physical conditions, things like HIV, tuberculosis, many of the non-communicable diseases, and it causes early mortality of between 10 and 20 years. We know that depression is a leading cause of illness and disability among adolescents, and suicide is the second leading cause of death. 1 in 5 youth worldwide will experience a mental illness before they turn 25, and about 70% of these disorders emerge by age 14 and often go undiagnosed for up to 10 years. Violence, poor school performance, disruptive behavior, social isolation, and the perpetuation of cycles of poverty in families have all been associated with undiagnosed and untreated mental illnesses. Youths must be facilitated to achieve their full potential and to make worthwhile contributions to national development. Right there, we can see where investment in health can break some of those cycles of poverty in families and set the course for stronger, healthier, and economically viable families and communities. About 3% of Jamaicans have a depressive disorder, and about 4% have an anxiety disorder, with women having slightly higher rates than men. Psychoses affect 1% of the population, but together with schizophrenia, the psychosis and schizophrenia together account for about 80% of the visits to the public health facilities for mental illness. As I mentioned earlier, Jamaica completed an investment case for mental health in collaboration with the Pan American Health Organization and RTI International. This study was done and it showed that by investing in scaling up of treatment for depression, anxiety, and psychosis, while we know that's not all of the mental health conditions, if we invested and scaled up treatment for those 3 conditions alone, there would be a return on investment of $2.4. That's a more than 100% increase of the returns after 5 years, and a $4.2 for every dollar spent after 15 years. So in closing, I want to say that mental health is more than just the absence of mental disorders. Mental health is an integral part of health. Mental health is determined by a range of socioeconomic, biological, and environmental factors. And we are aware of cost-effective public health and intersectoral strategies and interventions that can promote, protect, and restore mental health. We need to acknowledge them and work consistently so that they can make a positive impact on the health and well-being of the population. Thank you.
I'm sorry, Dr. Goldberg? Dr. Goldberg? We have not been hearing you. Still not hearing?
Yes, you hear me now?
Yes, sir.
Yes, so yes, thank you, Dr. Harris, for your remarks about mental illness and its connection with non-communicable diseases, and the fact it's very integral, and that the psychosocial factors are very important to bear in mind in order to ensure persons can achieve optimal mental health and optimal health in general. Now I'm going to move to our next panelist, who is Mrs. Yvonne Grant, who have a wealth of experience in working in a first world country, in how they would have invested in treatment of persons in that first world country. So I wanted to give us some insights as to what she would have observed and participated in while she was all the way in our mother country, England. Over to you now, Mrs. Grant.
Sorry, you weren't hearing me. Okay, can you hear me now?
Can you loud and clear? You can start from the top again. Welcome.
Start from the top again. Okay, good evening. And thank you very much, everyone. I'm saying that investing in mental health of homeless individuals working abroad with the 18 and 58. And so it means that
I think you should probably stop sharing your picture or video, might hear you better. Not hearing so well.
right, I think I got lost a while ago. Are you hearing me now?
I hear you now.
Yes, okay. I'm going back to say that my experience, I've been working with persons during their productive years, between the ages of 18 and 50, 58, 59. And with the right services, the ripple effect is so great that persons who have diagnosed mental illnesses, we work with individuals even since I've been here and at Open Arms. Research shows that 60% less. At Open Arms, we are getting like a 35, 40%. And with the structured care that we give, we have persons who have diagnoses. We make sure they take the treatment. We work with them to develop a compliance. We work with them on a compliance regime so that they learn that they really need to take the medication. They need rehabilitation work and the reintegration work with them. And that causes some persons who have real chronic illness to be able to function at their maximum potential. But the other 60% who have no diagnosis, when we invest in their health, mental and physical, as the doctor said a while ago, then it means that we don't wait until they are exhibiting symptoms of some problems. And there is no good health without good mental health, on the social, on the spiritual, and on the physical, and give them a holistic program. So we sit with them and goals and get them to work towards those goals.
You might have to stop sharing your
So we
better.
and also having like it. Because like for years people work hard never worked. They have jobs. They maintain those jobs. They maintain relationships. And most of them, we get them returning to the community as productive citizens. So investing is not just financial, but it is opportunities and care, holistic care. And so we reap a lot of benefits. So the investment and the returns are great, because people who would be dependent on the state are out there working, taking business and doing, really, really good and being positive, and are also able to help others. Because we've got some who have started their own business. Last year we had 2 persons did level 3 in entrepreneurship, and one guy has a mental illness, has a diagnosis, and the other one had suffered some depression. And so we work with individuals, and when you invest in the homeless, the rewards are very, very great, very great. I think I've done my 4 minutes.
Okay, thank you very much, Nurse Grant, sorry your audio not so well. You might have to not use your video so we can hear you better. But thank you for your contribution about what can happen when we actually spend the time and the effort and providing necessary services to persons who may have impairment due to mental illness to improve to a high level of functioning. We move to our next panelist, who is Nurse Molly Thompson, who has been for years being the Regional Mental Health Officer in the Southern Regional Health Authority, and in recent months has assumed the post of acting executive officer at Bellevue Hospital. She comes up with a wealth of experience of what it is to look after mentally ill persons within the community and the measures that we use to try to see how we can invest in their well-being in order to achieve the optimal outcome in their existence. Over to you now, Ms. Molly Thompson.
Good evening, all. Looking at the Jamaica situation, we know and we that from working in the community, we have identified that there are quite a number of, I deliberately didn't start the video because I didn't want for any problem with the connectivity. But from working in community, we know that there are quite a number of issues in community mental health. We know that quite a number of the persons we see are persons with psychotic disorders. We have issues specifically now with COVID in terms of increased levels of anxiety, depression. The minister alluded to some of what have been happening with COVID. We have reports of violence and levels of abuses have increased. And of course, the substance use and misuse. I know that the person from the National Council will address those. We also have looked at issues with suicide and suicidal behavior, as well as with homelessness. Now, why invest in our mental health? Why should we invest in it? What are the returns on investment? For one, if we can invest more, a lot has been happening over the quite some period of time, but if we can invest more in our mental health to reach a point where we have more focus on community intervention and strategies at the community level, it leads to early diagnosis for persons. We find these individuals quicker and we are able to implement treatment quicker that leads to a better outcome for individuals within the community. And by extension, if we are able to do that, it will eventually lead to less admissions to hospital. So it's very important that investing in our mental health services, we focus a lot on what happens at the community level so that we can improve what is happening. Once we're able to do that also, it reduces the burden on the mental health services. I mentioned about hospitalization. For example, we have some hospitals or the hospital I'm at sees or admits about 53 to 60 persons per month. And once we are able to invest in our communities and the mental health services at that level, it can help to reduce these hospitalizations. Let us look at also our response to crises. We know that that's one of our problems as well. We're not able to, reach out to them as quickly as we want to. Yes, the buses are here, but it seems like having the buses, cases are just going out of control at times. And so once we are able to, again, I'm emphasizing the need for us to improve on our community mental health services, and then we can see the reduction in some of these crises. And of course, when I talk about crisis, we're talking about cases of aggression and suicide behavior. What again do we look at? We look also at emphasizing more mental health promotional activity. And that is one of our greatest investment that we can make when it comes to mental health. Because considering that there is still a number of stigma, high level of stigma associated with mental health conditions out there in the population. People are still afraid of the word mental. And so once we can improve the educational and promotional sessions and have everybody understand the whole process of mental health and how we can promote good mental health, it is a good investment to also help, because we know that once persons are stigmatized, they don't want to access treatment. They are afraid to go. They don't want people to know that they have mental health problems. This leads to problems with compliance, that leads to problem with relapse. And so it's very important for us to look at, mental health promotion. But we have been doing so. What we're hoping for is that it will be more. There'll be more as we go along, as we move forward in the years to come. All right. We know that, and we have heard about the return on investment. I know Dr. Harris has spoken about the situation with PAHO in their studies and looking at the situation. And I know she will speak as it relates to that, and have mentioned it. And so if we're able to focus again on community, the cost for care in hospitals and other services will be significantly reduced. If we can invest more in identifying persons early, cost for care will be reduced. That's what I'm saying, will be reduced. All right, it will be better outcome for children if we can invest more in parenting training and helping persons to understand how to help their children grow mentally healthy, or what we will call have emotional intelligence. And so it leads to better development for them, reduce in the potential for increasing violence when they grow as well. And so, and also, I've mentioned the issue of substance abuse. I won't go into that because I know Ms. Curlew will speak on that. But these are some of the benefits in Jamaica if we continue to, because a lot has happened. If we continue to invest in mental health, these are the benefits that we can reap as we go forward. And those are my words. Thanks.
Thank you, Ms. Mullins Thompson, for your remarks, reminding us that if we invest early and effectively in managing a person with mental illness, then the costs that are associated with it will be so much less, and also the costs to their own level will be so much less, where they can be more productive. And of course, you mentioned about mental promotion being a necessary part of what we need to have happen to ensure persons be more receptive of them in the communities. We move on to our next panelist, who is Ms. Colette Curlew. She's the Director of Client Services at the National Council on Drug Abuse in Jamaica, which is a team with the implementation of prevention and treatment programs across the island, with special projects in reducing drug use and improving quality of lives of not only persons who are, of lives of staff and fellow citizens. She's a trainer of persons who trainers for treatment of substance abuse for adults and adolescents. She was involved in Jamaica style parenting, which is formal training in pre and post marital counseling. She has a master's degree in counseling psychology and a degree in business administration. And her life goal is to empower persons to live victorious and joyous lives. So I asked Ms. Curlew to give her presentation, and she gave her perspective to come from the National Council on Drug Abuse. Ms. Curlew, over to you.
Thank you. Good night. Thanks for having me, Dr. Goldberg, and all protocols observed. Today, it gives me great pleasure to talk about the investment for prevention and treatment of substance use and to discuss what are the returns on it. Now, a snapshot of our national situation: alcohol still remains a drug of impact for most persons. It's widely used by adolescents and or adults. Ganja is the next drug of impact, and that is it's the most widely used illicit substance with a low prevalence of crack cocaine. there's a narrowing of the gender gap. Initially, you would find that males were predominant in it, but although that's still so, the females are narrowing the gap. And adolescents report that they have access to these substances and their risk perception is low. And what you find that what is associated with drug use is exposure to it. The adolescents have it in their homes, the low perception, as I said, to harm, there's lack of parental bonding or support, and behavioral problems will increase drug use. Now, what the treatment data shows us for the period 2013 to 2017 is that over 92% of the clients in treatment were males. Additionally, about 70% of them were under the age of 30, and the majority of them were, or 49% of them were educated at the secondary level. Almost 50% of them were in treatment for cannabis, 38% for crack cocaine, and 20% for alcohol. And 10% have been arrested in the past year, while 46.6% were previously arrested at some point in their lives. So we see there's some link to crime where that is concerned. Now, drug use does impact our economy. It impacts our health, our social and economic factors. On health, what you find there are two NCD, drug use, alcohol and tobacco are linked to NCDs, non-communicable diseases. There's drug-induced deaths, there's burden of disease, and there's the injury and hospitalization that may happen. And there's the mental health, that the impact on mental health, as well as you can have pregnancy complications, and we can have other harms related to drug use as risky sexual practices, and that can lead to the prevalence of HIV and other STIs. The social impact that you can have is that you have risky sexual behavior and criminal activity. There's the family and domestic violence, and you find that the family bondage will break down with that, where that is concerned, and they will come in contact with the criminal system, and there'll be victimization and trauma. The economic cost of that is that you'll find that persons will lose their job, the household expenditure will be impacted, and there'll be lost productivity at the workplace. To solve some of that, for the past, I think, 3 successive terms, we have tried to implement a national drug master plan. And the overarching aim of that is to help come with the demand, supply, and demand and reduction in supply reduction. So let me do that again. The aim of the master drug plan is to reduce the demand and also the supply for drugs. So we would look at prevention and treatment intervention. On the demand side and on the supply side, we would look at international control, interdiction, and law enforcement. What we find is that when you do a gap analysis of the institutional framework, there's a lack of adaptation of the National Drug Master Plan. So that is something that we still need to do. It will help to create and accentuate the response to this. We will come together as a team and have a consistent and unified approach to it. And it's a balanced approach using a public health approach. So that is still need to be adopted, and we need that done urgently. We need to have national policy framework for drug, for the supply reduction, for prevention, and also for treatment. And also we need to look at standards of care. What we need to do is formally link the services as well between mental health and substance abuse, because we still have that as, we're creating that bond now, but it needs to be formalized. Some of the barriers that are there to improving the drug situation include the lack of champions. We need somebody to go there and take this on, because what happens is this is not seen as sexist sometimes, and even artists shy away from it because sometimes their sponsors will not support them after they endorse a drug demand program. But we need a champion to help lead it. There's inadequate support for the youth, and I think we hear that consistently in the presentations this evening. There's poor screening practices as well. We need to have that done at the primary healthcare level, where they do screening, brief intervention, referral in the schools and at the community level. We need to have medical promotion. The media promotes it more than us. So we need to have more funding in place so we can do more public education campaigns. Are you hearing me? Okay, thank you. And there's inadequate counter messages on the media platform. So you hear, I'm drinking rum and but you're not hearing, do not give our children drugs. So we need more of those messages in mainstream. There's lack of strong enforced policies as well. So when the young man, the 3-year-old, not young, that baby that was drinking the other day and smoking, we need proper enforcement so that won't happen more. We need adequate funding as well, because there's inadequate funding, and of course the cultural acceptance, which is why the young boy was given it, the cigarette and the alcohol to show the rite of passage. So those are some of the barriers that we have. What is recommended is that we increase the political will to address both demand and supply reduction. We need to adopt and we need to implement the drug control master plan that will help us with the supply and demand reduction. We need to develop treatment and prevention policies. Where do we go when we need to audit a drug treatment facility? What are the standards that are there? So we need these standards to be implemented and adopted. We need policies in place. We need legislation in place. We need quality and the quality standards of care to be there for both prevention and treatment. We need to invest in adequate human resources and institutional resources. We do not have enough treatment facilities to cater to the needs of our population. And we do not have enough persons in there to man those facilities as well. And we hear that drug use is on the rise. Know that there's COVID and people are, what they said, we have to stay home now. So there's more drug use that's happening. And we need to include substance misuse into the broader mental health plan and policy. So it needs to be more integrated in there. We need increased access to treatment in the primary health care, as I said earlier. We need to do more screening and brief intervention. We need to do testing when somebody comes in with an accident to see, was that the cause of the accident? And these things are linked to NCDs. So we need to be at the primary level to be taking more care there and do the screening and brief intervention and referral to treatment as needed. We need more facilities and the personnel. We need more training of personnel as well. And we need to increase the national investment in ongoing research and surveillance system to inform the policy and programs that's happening versus only rely on external funders to do so. Now, we have made some notable advances. There's an increase in the average age of initiation from 12 to 13-year-olds. So we rejoice in that. We moved from 12 to 13. That took us about 7 years to make it happen. There's now an improved data collection system. So we have the drug information network, we have the early warning system, we have the CANWAT surveillance system, which is our very own. And we're now translating the evidence to build out our programs and also to inform policies. So there's regional and international partnership. I'm sure Dr. Harris will agree. And we have CARICOM, OASICAD, COPALAD, and UNODC. We have national partnership to Mrs. Grant would know with our Take It to Them, and we have it within the ministries and other NGOs and private sector and AFOSFOSA as well. So, and we are now incorporating our youths more in drug prevention efforts internationally and locally. So we have youth ambassadors through CICAD and UNODC. Now, what will we get on this return on investment? We will achieve some of our international targets. Some of them are SDGs goal, to primarily talking about goal 3, target 3.5, where we will strengthen the prevention and treatment of substance abuse, including narcotic, drug, and harmful use of alcohol. We will also be meeting some of the WHO global NCD targets for 2025, which said we would have 10% reduction in harmful use of alcohol and 30% reduction in tobacco use. We'll also help to accomplish our Vision 2030, that is our local targets. We will also reduce the adverse health and social consequences, as well as reduce drug-related crime and violence, delay onset of drug use, and we'll have happier lives and more integrated children, especially if we invest in the prevention and inform population that will make better choices for our future Jamaica. Thank you for the opportunity to share, and we look forward to the return on investment.
Thank you, Ms. Carlo, for giving us a good overview, and just remind us that when person use substance, it's considered to be affecting the brain, a brain disease. And can affect the brain, affects the mind, so it becomes a mental health issue. And thank her for telling us about the different complications, consequences due to use of substances and affecting male young males. and also what are the measures being taken to reduce the demand and supply of drugs. So we're going to go forward now to the questions now. There's a question here. So what will be done to reduce the demand and supply for these harmful substances among the youth? Can you tell us what are the measures, Mrs. Curlew? Ms. Curlew?
Yes, sorry, go ahead.
Yes. A question here. What will be done to reduce the demand and supply for these harmful substances among the youth? Say, so the youth are mainly affected, especially young males. What is being done and what can be done and what can't be done?
Thank you for that question. So we are into prevention. That's one of our biggest things. 66% of our time is spent in prevention. We're in schools, we're in communities, we're empowering peers as well to do intervention. So we're doing programs in schools. Now school is off now, but what we're doing is digitizing our programs and making them interface on the social media so we can reach them on that platform now. So we're reaching them through EduFocal as well and Education One-on-One. Those are two platforms that are coming that we'll be offering our programs on. Our substance abuse officers are in the field working in communities, because what we do is approach it at a community level. And then we go to the schools within the community to do the prevention programs. We're doing mass media campaign as well. Often you would have heard, well, reaching out to persons who need treatment, that we are here to help them with that. But for drug prevention, it is at the school level that we're doing it. We're increasing the family bonding as well. So we have parenting programs that are being done. We're also the community personnel, we're training them in how to protect the children. And we're talking to the shopkeepers. We're trying to get them not to sell to the minors as well. So I'm trying to remember. So, and we're doing peer educators training, because we recognize that to reach teenagers, it's best to use their own. So the teenagers will then go back and do peer intervention. So we're in primary schools, we're in high schools, and for university, we do harm reduction with them because they're adults. But more public education, we use our social media platform as well. So a lot of our messages are going through our Instagram. We're hearing that we need to be on TikTok, so we're investigating that. Where that is concerned as well. And we hope to get some young persons on the team to go out and reach more young persons. I hope I've answered, and if not, you can ask me other questions.
Then a question. You mentioned that there's a paucity or there's only few treatment centers across the island. Do you know what is being planned to increase those treatment centers?
I should ask you that question to Dr. Goldberg. We both can answer that. Certainly where we are concerned, we have increased our treatment staff. That's what we can do. We are also trying to get the minimum standards, or that it's not minimum, it's the standards of care ready for treatment facilities, so that at least for those that are not meeting the target, we can help to build them up to be of the minimum standards required. We would continue to lobby to get more treatment facilities in, and one of my recommendations was to integrate substance use more in the mental health plan. So to lobby the minister, lobby the PS, lobby the CMO, lobby the director of mental health and substance use, and also external partners, international funders for that. That's what we can do.
Thank you.
And we're training persons to do screening and brief intervention. I believe that's something that the primary healthcare center needs to happen in the primary healthcare facilities. That needs to happen more.
Yes, I agree with that, because that's also part of the integration we're trying to have between primary care and both mental health and substance abuse, where primary care physicians, who are the first contact persons with most of the public, we're the ones who do initial assessment, initial screening, initial intervention too, and we're for those who they may not be able to manage on a primary level.
I forget one thing, Dr. Goldman, if you permit me. What we have also done is to train guidance counselors, HFLA teachers, deans of discipline in screening, brief intervention, and referral to treatment. So they can do intervention in schools as well. So that will also help the children. And also, I guess, stem the flow into misuse from use.
Okay, thank you. Ms. Mullins Thompson, a question here for you. What measures do you see working in the community that has helped persons to recover from mental illness and be able to become productive? What are the measures you see working that we need to probably ramp up to ensure a person have a better outcome?
All right. What are some of the measures include one-on-one? For me, I buy into the whole case management approach. And so if we can go, to the community level and have individuals that would engage these individuals with mental health problem on a one-on-one. Of course, the minister would have alluded to getting community health aides to be a part of the program. And that was some mention of that was meant in the task force document, community mental health aides, that was what it was referred to. And so if we can have that one-on-one monitoring of patients and one individuals in the community, we can have a better outcome for clients at that level. So it's not just about going in and giving an injection. Sometimes you're out there and they want to talk, but then we have so many persons to see that we have to be moving from one point to the other quickly, and they can't spend the quality time they want to relate to each other. And of course, again, I won't stop emphasizing mental health promotion, a lot of it in the communities.
Thank you. Actually, someone said to me that actually we should increase our mental health promotion activities that will direct the public to more self-care. And when we look at the pyramid of care per persons, most of the persons, if they apply self-care, really look after themselves well, so eating properly, get enough rest, have enough social connectedness, then most persons will remain mentally well and won't have to go to the next level where they have to get more expert treatment.
I agree, Dr. Goldberg. But again, we also have to help to teach them how to do this and what are the strategies they need to do to, help themselves. Because we have to be doing a lot of that with COVID now, aren't we? Because the social distancing. So we have to be doing that, showing people how to monitor the psychosocial support from a distance.
Right. And that's why the psychological first aid training is so important in trying to reach as many persons in the community level, help them to cope better. So hopefully they won't reach a stage where they are decompensating and need much more expert intervention.
Right.
So at this point in time, bear in mind that we're in COVID situation where there's curfew. I'd have to thank our panelists for their remarks on the topic of investing in mental health. What are the returns? And from what you have heard from them, there's definitely returns if you invest in mental health. And if you don't invest, then you see there are a lot of deleterious effects, or what I call domino effect, which will cause our country to be not developed as it should, and cause both individuals and communities to be set back and cause people to have poor quality of life. So we thank you for being with us this afternoon, and we wish you all the best for the rest of the week of lectures. So we'll see you again tomorrow at 5. And thank you again. Have a good rest of the afternoon. Thank you for your participation. And good night.
Thank you.
Thank
Have
you.
a good night.
And good night to you too. All the
Good
best.
night, everyone. Bless you. Bye-bye.
Bye.